Welcome to RXP International. I'm Dr. Elaine Foster, and I have with me here today as a discussant Dr. Elaine Levine. And we are here to discuss the fascinating world of psychopharmacology of antipsychotics. Let's start with what we would like you to learn as we go through this course. First, it's important to know the symptoms that you're treating, and also to understand that psychosis is more than schizophrenia. There are many medical conditions that look like psychosis, and many drugs that mimic or produce psychotic symptoms. We're going to explore the medications that are used to treat this condition and the differences between them. Once you've started these medications or know that your patient is taking them, it's important to be able to monitor their effects. And of course, this would not be consistent with a psychobiosocial model if we didn't talk some about the importance of non-biological treatments, the psychotherapies. And in this case, because the population often requires more than individual psychotherapy, we're going to explore the empirically based treatments that are used on a social realm. These include family therapies as well as social skills building. One of the questions that I often hear from family members when a child has a first break psychotic episode is schizophrenia inherited? We know that 1 out of 100 individuals in the general population will suffer from this disease. But let's look at the other extreme, monozygotic twins. If you look at this chart, you'll see that for twins who share 100% of their genes, there is an almost 50% concordance rate, which means that if one suffers from the condition, the other will experience it as well. But even with that high of a genetic loading, we can see that there's still 50% remaining. What else might be causing the condition to express itself? We call the environmental factors that contribute to the expression of schizophrenia epigenetic factors. Anything that is not purely the genes. And so we know by looking at this graph that there are many other factors, and that is why schizophrenia is considered multifactorial. In your training, you may have already learned about the diathesis stress model, implying that when individuals experience stress, perhaps early in their childhood, trauma, or other environmental factors like toxins and viruses, that they can lead to the expression of this disorder. Many times we might have some trepidation in treating individuals with psychotic disorders because there are so many symptoms to track, and oftentimes these individuals don't come into your clinic or place of work describing their symptoms, but rather acting them out. We know that there are 4 domains that we must consider when treating this condition. First, let's look at the positive symptoms. I like to refer to them as HAL-D2. hallucinations, delusions, and disorganized thinking. The reason these are called positive symptoms is because they are symptoms that are there that should not be there. So it's almost like adding something on. And these often can be the most disconcerting symptoms because of the fact that the individual may be behaving in odd and bizarre ways. And it may be difficult during your clinical interview to wade through the expression of those symptoms. But now let's move on to the other side of the coin, the negative symptoms. I like to refer to these as A negative because they start with A and they're symptoms that shouldn't be there, such as alogia, which we often see as a poverty of speech, avolition, an inability to initiate actions or to stay motivated, asociality, which is an inability to interact socially, and then anhedonia, the inability to experience pleasure. But that's not all the symptoms. We know that there are cognitive symptoms, and I took the liberty of using the phrase, I think, therefore I are. And the R stands for attention, recall, and executive function. Remember that executive function happens in the prefrontal cortex, and it has to do with planning, organizing, and executing. Now, I think the most critical domain to consider or keep in mind as you work with this population are the mood symptoms. And appropriately, I decided to call those SAD because they have to do with suicidality, anxiety, and depression. One of the most important considerations to keep in mind when you're treating this condition is suicidality. At least 1 in 10 will complete suicide successfully, and 1 out of 3 will attempt. So we can't only keep our focus on the more dramatic positive symptoms, but rather we have to keep in mind that this is a very at-risk population, and we should be always mindful of the possibility that they are experiencing suicidal ideation and be prepared to work with that. Now, let's just briefly look at the assessment of psychosis. You've already been trained how to conduct a history of the presenting illness, and I'm just going to pull out a few more relevant considerations while doing the history. So, for example, you want to ask your normal questions about onset of symptoms, frequency, duration, and intensity. But in the case of psychosis, we want to explore beyond those positive symptoms that we described earlier and keep our minds open. This is an early stage where, as clinical detectives, we want to be open to all possibilities. So we know there are many psychiatric conditions besides schizophrenia that cause psychotic symptoms. Those can include bipolar and mania, severe depression, personality disorders like borderline, schizotypal and schizoid personality disorders, as well as post-traumatic stress, which can all present with at least transient psychotic symptoms. We also want to keep in mind that there are many medical symptoms or many medical conditions that can produce psychotic symptoms. I consider the past psychiatric history as a type of freebie. And by that I mean, when you ask about their previous psychiatric diagnoses, you may learn that they've already been diagnosed and treated for a specific condition that is associated with psychosis. Or conversely, you may learn that this is their very first break and they've shown no other history to suggest that they have a schizophrenic condition. The important aspect to keep in mind is whether these symptoms wax and wane or fluctuate. The reason for that is that delirium can look like schizophrenia, present with psychotic symptoms, but it waxes and wanes. It comes and goes. So they are not consistently showing psychotic symptoms or confusion. I'm just going to briefly discuss some of the more obvious conditions like headache in the medical history that I like to use an example that I experienced in my medical practice. While I was working in a hospital, I received a referral of a 40-year-old individual who was complaining of headache. His primary care doctor had done as much of a workup as he felt was necessary and finally decided that he did not need to see this patient anymore and that I should see him and treat him behaviorally for his headache. One thing I learned as a clinical pearl while I was attending the military medical school where I did my training was that any headache or psychotic symptom presenting after the age of 40 is considered a brain lesion unless proven otherwise. After I did my evaluation of this individual and discovered that his headaches had grown more severe, they were happening every day, and they lasted throughout the day. Ethically, I felt I could not continue to see him, and I referred him back to his primary care doctor, asking that he perform an MRI. The doctor did do so, and it turned out that he had a brain tumor. And this would not have been discovered if the condition had not been, if I had not decided to refer him back, but rather try to treat him as a psychological condition. So I think it's really important for you as a clinician to think about, does this make sense to you? And if it doesn't, you have the right to refer your patient back for further exploration or lab studies, radiological studies. We know that head trauma with subdural hematoma can press on various parts of the brain and produce psychotic symptoms. Also, dementia, as it progresses, can present with disorganized, confused, positive symptoms. And I won't certainly go over all of the medical conditions that can present as psychotic, but I would just suggest to you that if your patient is having a new onset psychosis and they suffer from a medical condition, check it out. Look to see whether that condition that they've told you they already have can express itself in psychotic symptoms. Finally, medical conditions that are expressed by the family. You remember the graph that showed that there's a higher concordance rate when family members have the same condition. So another freebie is to ask about whether family members have any condition that also is expressed through psychotic symptoms. We're going to talk more now about medications. I decided to pull out the anticholinergic medications for particular scrutiny when we review the medications that can mimic psychosis. Why? Because these medications are going to be used throughout your practice, no matter what the specialty. You can count on anticholinergic medications being used with so many conditions. Once you become sensitized to it, you'll be surprised to see how often these medications are used. There's always two sides to a coin, and as we've already seen, there's the positive side of using anticholinergics, but the negative side is there is toxicity associated with these medications. When you think about anticholinergics, I want you to think about the rest and digest aspect of the nervous system. Rest and digest is typically happening after you've had a meal, you're relaxed, you're in a safe environment, and your body is responding to the food in your stomach, increasing salivation, increasing digestive fluids. You're feeling relaxed and perhaps not mentally alert, but certainly not confused or agitated. Anticholinergics oppose the rest and digest system. And because of that, when taken in overdose, they produce the opposite. So we use these sentences to help us, and I apologize because I learned these in the medical school, but they may not make as much sense to you in other countries because they have some connotations related to the United States. If you think of some that make more sense based on your country, your culture, please let us know and we'll include them as we go along. But the symptoms are dry as a bone. And remember we said that when you're in rest and digest, you are salivating and you're relaxed, digesting your meal. Well, now you have the opposite. So you have dry mouth, reduced salivation, urinary hesitancy. The individual wants to urinate, but they can't start a stream. Also, they don't sweat. And because they can't sweat, they start to develop hyperthermia, increased body temperature. They become flushed. Think about the opposite of rest and digest again, but now in the form of fight or flight. If you see an animal that could hurt you, you want to be able to see it in the distance, not when it's right on top of you. In order to do that, your eyes have to dilate so that you can see further out in the distance and run. Well, this is why we see what is called mydriasis, which means a dilating of the pupil with these agents. When the pupil dilates, your patient will complain of blurred vision because they can't see things up close. And then finally, mad as a hatter. Anticholinergics in overdose can produce psychotic symptoms. And I've listed for you some of the common agents that have anticholinergic properties, but believe me, this is a very small sampling. There are many more, and I'll call your attention to the last two on this chart, antihistamines. Antihistamines often have anticholinergic effects, and your patients use them all the time. They take them for allergies, they take them for colds, and they may not realize the effects as they continue to take more, perhaps because they feel they're not working adequately, and the potential toxicity involved. And then, of course, tricyclic antidepressants, which are still very much in use for many reasons and do produce these anticholinergic effects.
Dr. Foster, you've already shared so much valuable information, but I'm so glad to see that you talked about the side effects early on. Now, most of the people in our classes will not be prescribing medications as such, but if they can recognize these side effects and alert the other practitioners about them, it can be so valuable. I wanted to share for a minute a case that you made me think about when I was in my early training of a young man who exhibited florid symptoms of psychosis. He thought that there was a sensor in his brain. He saw it come up with making ugly faces at him. He had a lot of symptoms that directed people immediately to a diagnosis of schizophrenia. When he was treated, and he began to say that he was having trouble with his writing, that his writing was getting smaller and smaller, and he couldn't make it bigger. And the prescriber said that he thought this was just an effect of the medication. And he also said that he was having strange experiences, visual experiences, not blurred vision, but rather that he thought his eyes were staring at people even when they weren't staring at people. And he was very embarrassed about it. And again, the doctor said, this is a side effect of the medication. I thought, even with my limited training, I don't remember hearing those as anticholinergic side effects. Maybe something else is going on. And you know that through that, we did get him referred for an EEG. And on top of the psychosis, he was having very serious seizures. So recognizing the side effects was extremely important, and recognizing what the side effects might be due to in terms of medication was something I could contribute without ever prescribing. That was very important in his treatment.
I think that's a very useful example because we know that micrographia, hypergraphia can be exhibited with temporal lobe epilepsy as well as Parkinson's. And so we're going to see that both conditions can produce psychotic symptoms as well. And I think sensitizing us to the idea that we're always searching, always making sure that we don't prematurely conclude that we know the diagnosis simply because we see these positive symptoms. The anticholinergics, as I said, are worth exploring in more detail because they are used throughout the world. And I thought it might interest you to take a look at a picture of the Jimson weed plant, also called datura. The active agent is atropine, and it's been used in many cultures. Ayurvedic medicine in India has used it to treat asthma by smoking it. The plant is even considered sacred, a favorite of the Hindu god Shiva Nataraja. In the late 18th century, James Anderson, an English physician, introduced it to Europe as an anesthetic. And the Zuni and Chinese have used it for analgesia and as anesthetics, producing unconsciousness. So you can see that a simple plant can have dramatic effects. And that's why the anticholinergic agents should always stay as a high index of suspicion when you are evaluating your patient with new onset psychotic symptoms. Here are some other medications that can induce psychosis. If you see here, you can read them, but what I want to highlight for you is that dopaminergic agents, in other words, agents that increase the dopamine levels, have a propensity for producing psychosis. Those are listed there for you, and they are not the only dopaminergic agents. The first three, L-DOPA, bromocriptine, and amantadine, are used to treat Parkinson's, which, just a quick word about Parkinson's, results from the diminution of dopamine in the brain. And then, of course, we see ephedrine, which is again, dopamine increasing agent, and it has stimulating properties. It's often used the same as the next one, phenylpropanolamine, to treat cold symptoms because they work as decongestants. Some of the others, I won't go over all of them, but maybe one of the heavy hitters that you might often see a patient on is prednisone. It is a corticosteroid used to reduce inflammation. It's not like taking ibuprofen or naproxen. This is the elephant gun of the anti-inflammatory world. And as such, it can produce very significant symptoms, not only of psychosis, but mania. Now, I'm sorry to be perhaps too graphic with these pictures, but I wanted to drive home a point, and that is that it's not only the prescription medications or drugs that can produce severe symptoms. I tried to pull out some of the most common ones for us, such as bath salts, methamphetamines. Now, MDMA also known as ecstasy, is used around the world. Crocodile was actually first produced in Russia, and it's responsible for the necrotizing effect that you see there on the hand to your left. It's called a flesh-eating drug because, as you can see, at the site of injection, it tends to produce gangrene and, as I say, a necrotizing of the skin. That would be an obvious sign that your patient may be using illicit substances. On the right, you see an individual who looks normal before he started to use methamphetamines, but then afterwards, after chronic use, you see that he has multiple excoriations on his face. I want to use that picture to remind you of a useful way to remember the effect of illicit drugs, which your patient may not disclose to you. You can ask, do you use recreational or illicit drugs? And they may say no, but there's a type of hallucination that we see with individuals who use drugs that we don't as commonly see in schizophrenia, and that is tactile hallucinations. There's a fancy word for it. It's called formication. But the idea is that the patient will describe feeling like there are bugs crawling on their skin. This is, until proven otherwise, I like these little pearls to help me, but I would say that until proven otherwise, if you have someone who's complaining of formication, you should look for some sort of substance that's producing it. It may not always be illicit, but and it may even be alcohol, withdrawal mostly. But the idea being that when we see this, we want to explore for more exogenous agents that may cause that particular hallucination. Patients who we suspect might be using drugs, but it may be too long after the fact. Picture a psychotic patient that you've had to hospitalize, and they have been a few days out of their drug use. And let's just take a quick example. So let's look at amphetamines. You will pick up on amphetamine use up to 48 hours after ingestion or however it's been used. But the idea here is that if you're checking on a tox screen for amphetamines 1 week after they've used, it will present negative. And you really don't have the appropriate information or the correct information because you've simply looked for this drug too late. It's already out of the bloodstream. I'll also tell you that I've had cases where I've done a tox screen and I know the patient has taken the drug because they've told me that they've taken it, and in a particular case, it was a benzodiazepine. And if you look, it says that I should be able to detect a benzodiazepine 6 weeks with high-level use. And yet, this patient came up negative on our tox screen. So it's a way to sensitize you to the fact that lab studies are not 100% accurate and should not be used as your only form of information.
Dr. Foster, For those that are listening that may not know about tox screens, I was wondering if you could elaborate for a minute on how they do them. Is it urinalysis or blood tests or hair tests, or what exactly are we talking about?
In the typical clinic, you will do a tox screen through blood serum. So they will usually have the patient go down to the lab, and they'll draw blood and come back with a whole toxicology panel. Now remember that the panels, they can differ by clinic, and what one clinic may consider a toxicology screen, another may use completely differently, and you won't get the same comprehensive drugs. So that's something to keep in mind. Urinalysis is sometimes used as well, but for the more comprehensive tox screen, it's usually done through blood. Just some quick things here. I think even more relevant in some of the other countries where agriculture is more important and there are various exposures, we want to keep in mind that an individual's occupation may expose them to various heavy metals like lead, arsenic, mercury, and manganese. These can all have toxic effects with chronic exposure and result in psychotic symptoms. The organophosphates that farm workers are normally exposed to through pesticides can also build up and produce these sudden onset psychotic symptoms. The other thing to keep in mind is that you may not only be exposed to pesticides through farm work. Foods that have not been properly washed can also expose an individual to pesticides at toxic levels. Beyond work history, it's worthwhile to take a look at the individual's diet. It's always fascinated me that deficiencies like B12, folate, thiamine, and niacin can produce psychotic symptoms. And we see those with vegans, vegetarians, and also symptoms or conditions of malabsorption. Individuals who may have had bariatric surgery may experience malabsorption and show first onset psychotic symptoms. I want to share with you a quick case of a vegan who was seen. He was 31-year-old Taiwanese male who presented with psychotic symptoms and was admitted for acute paranoia. At first, he was placed on an antipsychotic and stabilized, discharged from the hospital. But then 7 weeks later, he was floridly psychotic and back in the hospital. A new doctor evaluated him and asked about his diet. It turns out that he was a vegetarian since he was a teenager, and his only source of vitamin B12 was from a minimal amount of dairy products. The physician discontinued the antipsychotic and replaced it with 1,000 micrograms of B12. His symptoms improved in 2 weeks, and 1 year after discharge, he continued to be asymptomatic purely because he changed his diet and was able to use B12 supplementation. Travel history is important as well because we can be exposed to various parasites and xenobiotics that our body has not raised antibodies to. And this can be an important factor to consider because it can help with the lab study that we may use to try to understand what is causing these psychotic symptoms. Sexual history. I always think back to a lecture that I had regarding syphilis. And the reason that I think that it stuck in my mind is because it was so fascinating. The idea here was that we see far less cases of neurosyphilis now than prior to the development of penicillin, I believe in the 1940s. And the reason for that is because antibiotics have been used so commonly now for so many conditions that without intending to, we actually are treating syphilis that the patient never disclosed or may not have even known about. And I discovered this when I saw an 80-year-old individual who was on our inpatient unit and presenting with a rare case of neurosyphilis. We thought it was dementia at the beginning with psychotic symptoms, but with the lab study, which is common in the screening labs that are used when we are first presented with a patient who is showing psychotic symptoms, includes something called an RPR, reactive plasma reagent. And it's used to determine whether a person may suffer from syphilis. And in his case, he actually was positive on this lab study. We also know that HIV/AIDS can also, in later stages, produce with psychotic symptoms. And often with the sexual history, it can help to have collateral or informed sources when conducting the interview or considering differential diagnoses. Here are the laboratory studies I was talking about. We certainly don't expect you to know them or to use them, but it helps to get a sense of the various types of measures that are used to identify possible organic causes for your patient's symptoms. Here's a clinical case to get you thinking about some of the things that we've just learned. And maybe now that you have explored the medical assessment, you can start to use some clues to help guide you in your differential diagnosis with this new onset psychosis, the case of the paranoid college student. Jimmy Crystal is a 29-year-old, previously healthy male who attends the local college. He presents to your emergency department while you are on call and complains of palpitations, tactile and visual hallucinations that he's had for the past 3 days. He's showing some poverty of speech. He mentions that the other students at the college have been messing with his stuff and that he believes the police followed him to the emergency room. He's irritable. He complains of insomnia and weight loss, headache. The weight loss is pretty substantial, 15 pounds in the past month. I like to break up the assessment into different dimensions. So for example, on a continuum from normal to floridly psychotic, where does this individual fall? Well, in Jimmy's case, we see that he has delusions and hallucinations, so he's falling more toward the extreme. His appearance is disheveled. We're looking at his beliefs. Do they appear flexible or are they rigid and bizarre? In the case of students messing with his stuff, is that possible? Sure, it's possible. Could the police have followed him to the emergency room? You may look around. Do you see any police? Still possible, but maybe not as common as the students messing with his stuff, especially if the doctor who has consulted with you on this case doesn't bring up anything about police hovering or being interested in this case. The perceptions are also important. Remember that we talked about tactile hallucinations not being as common with schizophrenia, but yes, being more common with another type of cause, which I won't mention right now. The thoughts are paranoid, they're disorganized. His communication suggests poverty of speech. His emotions are irritable, he's suspicious, his behavior is agitated, and we've got a very short course, only 3 days. There are other relevant factors which are more physical in nature, like his headache, insomnia, and acute weight loss. So let's look at the physical exam. We see that he has a temperature, 101. His pulse is 99, so it's racing, and his blood pressure is elevated, 180 over 95. He looks underweight. Remember we talked about the dilated pupils known as mydriasis, causing him to experience blurred vision. He's sweating, that's called diaphoresis. His heart is racing, that's called tachycardia. His skin is flushed. We see some excoriations on his arms, torso, and legs. He's got brisk reflexes. He's tremulous, agitated, and his speech sounds pressured. Jerry's girlfriend solves the case. She tells you that he's been injecting methamphetamine. What clues did we see from the presentation? We've got almost all physical exam findings that are consistent with some form of stimulation. Remember, his heart was racing, he's flushed, he is agitated, his temperature is elevated. He was previously healthy, so that again raises the index of suspicion that this is probably something that is exogenous, meaning not coming from inside. His tactile hallucinations hopefully now are a good tip-off for you, because we talked about formication and these excoriations that you can often see because the individual is trying to pick or scratch at that sensation that they're experiencing. The irritability, again, often seen with use of stimulants. And then the insomnia and weight loss. Remember, people have often taken stimulants in order to stay awake. Picture the typical student who may be not suffering from ADHD, but taking it purely to stay up longer for their exams during finals. We also know that they're used for weight loss and they produce headaches. So with this type of presentation, hopefully now you've come to realize that there are many clues that we saw in his symptomology that allowed us to come to the conclusion that without Jerry's girlfriend, although of course that makes it easier, to know that there may have been some type of stimulant in Jerry's life.
Dr. Foster, I know that soon you will be telling us about different medications to treat schizophrenia. What I'm wondering, suppose you do decide the person doesn't have schizophrenia and it's substance induced or they have some other illness like Parkinson's, are you saying that they're not going to be treated at all with antipsychotics because they're not really schizophrenic?
No, sometimes we use the antipsychotics purely to stabilize them. But many times we may not have to go as far as to offer an antipsychotic. We may use some of the more minor tranquilizers, such as the benzodiazepines, or other agents that may be used to stabilize the condition itself. So, for example, with anticholinergic toxicity, we probably would not be giving an antipsychotic because that could actually worsen the condition. And we may use something like physostigmine, which is the Narcan or the antidote to the anticholinergic agent. So it's very dependent on the condition itself and whether antipsychotics would improve or worsen it.
Oh, I see. So that clarifies it for me that you want to, if you find it's a different condition, you're going to try to treat that other condition first and foremost. But you may still need, with some of these people, an antipsychotic to deal with some of the symptoms. Do I understand that right?
Exactly.
Okay, thank you.
Let's move on now to the actual agents, the antipsychotics. We're going to start with the first generation or conventional agents. The two classic agents that you should know in this class are chlorpromazine, which is fascinating to think that the first antipsychotic was developed in 1954. And so this is important to start with chlorpromazine because it is the first and it is a low potency agent. That's going to mean more to you as we go along, but let's contrast it with haloperidol or Haldol, which came somewhat later, 1967, and it's the counterpart. It's a it's a high potency agent. Then, of course, there were these other subsequent agents that came along, and I've listed them for you there, and also designated them as Me Too D2. And there's a reason that we call them Me Too D2. Take a look at this three-dimensional molecule, dopamine molecule. And it's going to start us on our path toward understanding the antipsychotics. Remember in the primer, we discussed the neuron, presynaptic, postsynaptic. As you see here, we have a neuron that is displaying the neurotransmitter dopamine. It's derived from tyrosine, which is converted to dopamine by L-DOPA. It's sitting there in its little vesicle, waiting for an action potential to come coursing through. When that happens, it's released presynaptically into that synaptic space. And as you see on the postsynaptic receptor, the dopamine neurotransmitter is going to make its insertion into that dopamine receptor like a lock and key, as we've described. Now, why is dopamine important? This graph will help you to see that all the typical antipsychotics, and by the way, when we talk about the first generation antipsychotics, they have multiple names. They're known as first generation antipsychotic, neuroleptics, and typical antipsychotics. The idea here, when you look at this graph, is that the drug potency is very much correlated with its binding affinity to the dopamine 2 receptor. And as you see, they've listed chlorpromazine as a low potency agent, haloperidol as a high potency agent, and they've even included some of the atypical antipsychotics. But we're not going to go there right now. We're going to stick with the first generation conventionals. Dopamine is found on various pathways within the brain. The key dopamine pathways are going to be important for you to know. And the reason for that is because when you understand the dopamine pathway that is being affected by our drug, it's going to give you a map as to the types of effects that you should expect to see when our antipsychotic agents are blocking dopamine in that pathway. So remember, the antipsychotic is blocking the D2 receptors. And also remember that we talked about the positive symptoms of schizophrenia or psychosis. These positive symptoms have a home in the brain, and that home is known as the mesolimbic area. That's part of that reptilian brain, the old brain, and it's responsible for the hallucinations and visual sensory disturbances that we see with schizophrenia and psychotic disorders. Then we have a part of the brain that is also blocked by our antipsychotics. Again, that flip side of the coin that we talked about, because we don't like the effects of blocking dopamine in the nigrostriatal area of the brain. This blockade causes us to see extrapyramidal symptoms, and we're going to talk about what those are later on. But for now, what I want you to think about is that the nigrostriatal area is responsible for the extrapyramidal symptoms that we see when we use these agents. This is a three-sided coin because there's another aspect to the treatment. Again, the downside of using these agents is that in the part of the brain which is known as the tuberal infundibular pathway, we get another negative effect from using our agents, which has to do with something called prolactinemia. That is a hormone that, when in excess in the bloodstream, can cause some bad side effects, which include galactorrhea, which is an expressing of milk through the breasts, and even an enlargement of the breasts that we see with these agents. And for men in particular, but also women, there can be sexual dysfunction effects, and as we said, with males, erectile dysfunction. I will tell you that if there's anything that makes a man scared to take these drugs is when you give them informed consent and they understand that there is a possibility that their breasts may enlarge and that they may express milk through them. Uh, I've seen people just stop the discussion right then and there. And what I try to explain to them is this is not a common side effect. But if for some reason you are the rare individual that it happens to, we will switch the medication. We're not going to let you suffer. The role of the prescriber, or in this case, just the person who knows about these drugs, is to help guide their use. And we certainly don't want them to feel that they are forced to take something that's going to produce these negative adverse outcomes.
Dr. Foster, I was just going to add on that I had a case where this was very upsetting to a woman also. I had a young college student who had a lot of medical problems, and another physician had put her on an antipsychotic, and when she started secreting milk, she thought it was all part of her her medical problems had gotten worse. So once again, you're knowing about the side effects as well as the effects of these medications can be so helpful when you work with your clients.
Excellent, because we're actually going to look at that. Finally, there's the mesocortical pathway, which is said to be responsible for the negative symptoms of schizophrenia. And this is mostly, again, we're back to the cognitive and negative symptoms, meaning that the individual, remember we used I think, therefore I are. So the attention, the recall, and the executive function symptoms are affected when we use these drugs, because D2 also has its pathway in the cortical area of the brain. So let's have some fun. Which dopamine pathway do you think is going to be described here, or is being described here? You're seeing Robert Manfred for follow-up after his psychiatrist prescribed fluphenazine. Fluphenazine being a mid-potency antipsychotic. He is embarrassed and waits until the end of the session to tell you that he has noticed some kind of fluid coming out of his nipples. He asks, "Do you think I have cancer?" Kind of like your patient that wondered if it was a medical problem. Which dopamine pathway is likely being affected here? And hopefully you have already answered that, tubero-infundibular pathway. And what could you say? What do you think? What would you say if you saw Robert Manfred and he asked you that question?
If I wasn't prescribing, I would be a little ginger in how I say it, but I would tell him that from my understanding, that could be a side effect of some of the medication that he's taking and might not be a sign of any physical illness, and strongly encourage him to talk to his prescriber about it. What would you say?
I would do exactly the same thing.
Okay.
Now, there is a reason for this graph, and it's just to drive home a point. The idea here being that the antipsychotic effect, as you can see in the line, it starts at 60. So with the occupancy or D2 receptor blockade at 60%, we start to get the effect that we're looking for, the resolution of psychotic symptoms. However, look just above that at the green line and see that at 80% occupancy, it becomes a different story. Now you are starting to see significant side effects from the use of these first generation agents. And that's important because with that little bit of window, you have that much wiggle room to get the person feeling better, and just a little more takes you past that into these serious side effects that we're going to talk about next. Let's talk about the extrapyramidal symptoms. They include, on the acute phase, akathisia, dystonias, and dyskinesias. Those are the ones that you'll see early on in your treatment. With longer term use, we see symptoms of Parkinsonism and tardive dyskinesia. I don't expect you to know what those are, but now we're going to explore each one. The case of akathisia. Akathisia is a 25-year-old schizophrenic patient who was brought to the emergency department for acute treatment of a laceration to her wrist, which was self-inflicted in what looks to be a suicide attempt. After the wound is dressed, you're brought in as a consultant, and you immediately notice that she's pacing and refuses to sit down. She's pacing and looking so agitated that you start to notice yourself feeling anxious merely by being in her presence. In an attempt to lower your own anxiety level, you ask her to sit down again, and this time she blows up and says, "You sit down, I'm leaving." Is this a worsening of her psychosis with psychotic agitation and suicidality? Or is this a type of anxiety or panic reaction? What might some useful questions be that you could ask her in order to determine what the causes of this unusual behavior? I'm sure you could think of many questions you would ask, but here are some that I considered. What medications are you taking? When did you start them? Have you ever felt this way before? And does this problem happen all the time or only during certain times or discrete episodes? I ask her these questions, and she says that she started the haloperidol 2 weeks ago. The restlessness started 1 week after she took the medication. The sensation lasts all day and night. She has never felt this way before, and in fact, she has never cut her wrists or attempted suicide before this. What is the likely diagnosis? Akathisia. That's why I called her akathisia, just to help you orient to this very troubling extrapyramidal symptom from the use of antipsychotics. It's an extremely unpleasant sensation. It includes motor restlessness, usually in the lower extremities, and usually much more so with the high potency conventional antipsychotics. That doesn't mean you don't see it with the atypicals, which we'll discuss later, particularly one called risperidone. But in the case of akathisia, we often see patients discontinue the medication. You see increased rates of noncompliance because you can just imagine what it must feel like to have this level of restlessness and agitation Oftentimes it's mistaken because the patient does look increasingly disorganized and hypophrenic. And so the first impulse is to consider increasing the dose of the antipsychotic in order to lessen those psychotic symptoms. But in fact, that's the worst thing you can do because this particular extrapyramidal symptom is dose dependent. Now, let's talk about another case that's going to demonstrate an extrapyramidal symptom. He's called Distone E. Oz. Distone is a 14-year-old boy prescribed metronidazole, metoclopramide, and paracetamol. Interestingly, I didn't know what paracetamol was until I traveled in Europe and discovered that it's our version of acetaminophen or Tylenol. In any case, Distone had taken these drugs in the morning and the afternoon, and by 6 p.m., he was agitated, he had difficulty swallowing, and showed an upward deviation of the eyes. At the time, he was suspected of having acute encephalitis. But the CT scan of the brain was normal. So they continue to explore the case. Here's a picture showing this, it's called oculogyric crisis. But essentially, it's what we just described, the deviation upward of the eyes in this case. There is rigidity of the neck and upper trunk muscles, which is why they thought he might have a meningitis or encephalitis. However, on physical exam, motor and sensory systems were normal. The exam was essentially normal, including the workup that they did for infection. You can imagine how disturbing it would be to see someone in this kind of distress and not know what to do. What I find the most fascinating about these cases is that given oral diphenhydramine, which is also known as Benadryl, the symptom in this case resolved within 12 hours. The finding was metoclopramide-induced dystonic reaction. What is metoclopramide? It's a D2 receptor antagonist. What do our antipsychotics do? They are also D2 receptor antagonists. In this case, metoclopramide was being used as an antiemetic, meaning an anti-nausea medication. And so it's important to know that psychosis is not the only reason that individuals may be prescribed these agents. What condition was Distone suffering from? It's a sustained spasm in any muscle group, but most often in the neck, tongue, or back. Oculogyric crisis is a type of dystonic reaction. When it happens in the larynx or throat, you can hear it as a form of stridor. That's that type of distressed breathing sound. It usually occurs within the first 4 days of starting a D2 blocker. And most at risk are younger patients started on high potency conventional antipsychotics. Also, Black males have a higher propensity for this particular extrapyramidal symptom. Thankfully, the incidence decreases with age and is negligible after age 40. The downside is schizophrenia in particular is a disorder that begins in adolescence most commonly, and therefore your population is most likely to suffer from this type of extrapyramidal symptom. Now let's talk about Mr. Parkinson. He's a 30-year-old male currently taking Prozac at 20 milligrams and Haldol, which we've already said, a high-potency antipsychotic, at 10 milligrams daily. He's taking it for a schizoaffective disorder. He presents to you looking depressed, his movements are slow, and he shows minimal facial expressiveness. It looks like a worsening of depression. So should you increase the Prozac because of that? Could it be a negative symptom that might require you to consider a different option in treating his psychotic symptoms? What else should you check to help you with your decision? This side effect, known as Parkinsonism, is not Parkinson's. So it's important to remember the difference. Parkinson's is a neurological disease that is caused by a reduction of dopamine in the brain, whereas Parkinsonism mimics Parkinson's, but is the effect of taking, in this case, a dopamine blocking agent, Haldol. It can be tested either way, whether it's Parkinson's or Parkinsonism, by testing for cogwheel rigidity, and I'm going to show you a picture in a moment of what that looks like. But essentially what you do is you flex and extend the patient's arm. What I typically do is say, first ask permission. I say, oh, you seem to be showing a particular symptom, like it may be a tremor. And I'll say to them, do you mind if I touch you in order to test something out about what might be causing this? And typically the patient says yes. I've never had one say no, but in any case, then, only then will I approach them and test for this cogwheel rigidity. When you do the test, and maybe I'll show on Elaine in a brief example here. So I would say, is it okay if I touch you?
Sure.
To test something with the tremor that you seem to be showing?
Yeah, sure.
All I need you to do is just relax your arm as best you can, okay? And so, yes, good, I feel the heaviness now. And you don't have to do anything. I'm going to do all the work. And so when Elaine is showing you what cogwheel rigidity looks like, because what's happening as I am extending and flexing, it feels like it kind of ratchets. It flows and then it stops. Then it flows and stops. And that's known as cogwheel rigidity. So thank you. We also see these slow movements, which again can look like depression, but is often in Parkinson's called mask-like facies. We just talked about the tremor. It's usually a resting tremor that we'll see in our patients, and that might be a good sign if the patient is looking depressed but is showing a new tremor that you never saw there before. that might help to guide you in trying to determine whether it's Parkinson's, in this case, I'm sorry, Parkinsonism, or whether it is a worsening of depression or some other condition. And here's a picture of a clinician testing for cogwheel rigidity. So, why do we use ancillary agents with our antipsychotics, particularly anticholinergic agents? Hopefully you remember now that we talked about how commonly anticholinergics are used. And here we go. Here's our first example within the setting of antipsychotics of use of anticholinergics. And what do? They treat the extrapyramidal symptoms that we have just discussed. And the reason that I've included these pictures is because I am a kind of slow learner when it comes to the physiology and all of these pathways and neurotransmitters. So I have to make it very simple for me to understand. And hopefully it will help you, because if you see this rider on a horse, I want you to picture the rider as dopamine and the horse as acetylcholine. Remember we talked about acetylcholine being the substance involved in the rest and digest parasympathetic part of the nervous system? Well, in this case, we see that dopamine has an inhibitory effect on acetylcholine. It's pulling back the reins on that acetylcholine. Now, what happens when we block that rider? Let's say we knocked him off that horse. Well, in that case, it would be similar to adding a dopamine blocking agent. When we add an agent that blocks dopamine, which is, we've also learned, is what our antipsychotics do, we knock that rider off, and now we see an increase in acetylcholine because he is no longer there to hold back or inhibit the acetylcholine. And that's why you see there on the seesaw that this kind of sinister looking antipsychotic, which is blocking dopamine, is resulting in an increase or rising of the levels of acetylcholine. Hopefully now this helps you understand why we need to give anticholinergic agents, because we just said that our antipsychotics are increasing the levels of acetylcholine. I don't expect you to know all of these, but it's important for you to see why we turn first to anticholinergics, and you see there the generic and brand names, as treatments for extrapyramidal symptoms: acute dystonia, Parkinsonism, akinesia, and akathisia. There are other agents that are used to treat these extrapyramidal symptoms. Antihistamines, which are very often anticholinergic in their effect as well. Remember, we discussed that in a previous slide. Diphenhydramine, also known as Benadryl, will quickly relieve these extrapyramidal symptoms, as we saw with the earlier case using metoclopramide, resulting in dystonia. But then there are also benzodiazepines that can be used as well for acute dystonia, although it's not a first-line agent. And in fact, you probably, without any prompting, would have even considered to use a tranquilizing agent like a benzodiazepine for a Kaisha who suffered from akathisia because she looked so restless and so agitated. I separated tardive dyskinesia from the rest because of the fact that it tends to occur later with more chronic treatment. The symptoms include continuous and repetitive movements of the mouth, tongue, and jaw, facial grimacing, lip smacking, puffing up the cheeks, uncontrollable movements, or swaying motions of the trunk or hips. Tardive dyskinesia is believed to happen as a result of what's called an upregulation or supersensitivity of dopamine receptors. So imagine blocking these dopamine receptors. Whenever you do something to the body, it always tries to compensate and reestablish some form of balance. And what these receptors are trying to do is become more sensitive so that the very little bit of dopamine that is being transmitted can be used. But in doing that, what we see are these symptoms, which we've already described as tardive dyskinesia. We know that it happens later on in treatment, and the graph hopefully demonstrates that, where you can see that at 5 years, about a third of the patients using neuroleptics or conventional antipsychotics will show some form of tardive dyskinesia. We also know that women, elderly women, with bipolar disorder, of all things, are more likely to suffer from the condition, and we also see it more often in African American women. I thought I would show you a instrument that is typically used at baseline and then for monitoring the symptoms of the antipsychotics. It's called the AIMS, the Abnormal Involuntary Movement Scale. And as you see here, I'm not going to go over it with you, but I just want you to see that there is a systematized way to look at the pre-antipsychotic or baseline presentation of your patient, and then the post-treatment effects through the use of this AIMS protocol. It looks like facial oral movements, extremity movements, trunk movements, and then you are able to provide global judgments. One thing it does call your attention to is that sometimes tardive dyskinesia, especially the oral dyskinesias, can actually be mimicked by improperly fitting dentures. And for that reason, you are asked to question the patient about whether they wear dentures to begin with. Just another quick side effect, it's not considered an extrapyramidal symptom, but is obviously an important consideration in your patients who take antipsychotics. It's called QT interval prolongation, which is a lengthening of the I want to say the polarization, deep and repolarization of the heart.
Let's see.
But how's a better way to say it? Which is a lengthening of the QRS. They're not going to know what that is. See, that's why.
Let's see. How about just saying it creates an arrhythmia?
Well, it wouldn't be a arrhythmia.
Well, it changes the
The length
the
that the heart...
cardiac rhythm, which can lead to an arrhythmia.
Okay, it changes the cardiac rhythm. Is that good for a layman? Okay. Which is a lengthening of the cardiac rhythm. There's a drug that is often used as the prototype for this kind of prolongation, which is called quinidine. And so they often refer to the effects of our antipsychotics as having quinidine-like effects. The ones that are most responsible for causing this type of heart abnormality are chlorpromazine, which is thorazine, thyroidazine, mesoridazine, pimozide, and haldol. I'm sorry, that should have said haloperidol. But I don't want you to lose sight of the fact that QT prolongation does not only occur with conventional antipsychotics. We'll talk later about the atypicals, and we'll see that they also cause the same symptom, but to a lesser degree. Here you have a chart showing you the various first-generation antipsychotics and breaking them down by low potency, medium, and high potency. Hopefully now you understand the reason for breaking them down into those categories, because we've already mentioned how often we see extrapyramidal symptoms with high potency agents. The way I like to remember it is that low potency agents are low potency because they have multiple binding affinities. And many times they're referred to as dirty drugs. The reason they're dirty is because they have multiple binding affinities rather than selecting the exact D2 receptor that we would ideally like to have if we had a perfect drug. But the good news with these dirty drugs is that they cover some of the side effects that we normally would have to treat with another agent. So remember, we just talked about adding an anticholinergic agent to our antipsychotic in order to cover for the fact that we've got this rise in acetylcholine. Well, our dirty drug, also known as a low potency agent, does that in and of itself. And we typically don't have to add an anticholinergic when we use drugs like chlorpromazine or thyroidazine. And here you have, again, basically what I've been describing. The low potency agents like chlorpromazine show fewer extrapyramidal reactions. However, again, being dirty drugs, they tend to produce more sedation and postural hypotension, which means that when you stand up quickly, you get this head rush or dizziness, and that is based on alpha-1 effects of a drug. You don't need to know that as much as to know that these low-potency agents can produce postural hypotension. They do have a greater effect on the seizure threshold and more cardiovascular effects in addition to weight gain. The high-potency agents are more likely to produce extrapyramidal effects, but they have less sedation, less postural hypotension. They don't tend to affect the seizure threshold as powerfully as the low-potency agents or be as cardiotoxic. They have fewer anticholinergic effects, as we've already said, and they produce a greater risk of neuroleptic malignant syndrome, which is a lethal, sometimes lethal condition that we see with the use of high potency agents. We've just talked about the conventional antipsychotics and all of their nasty side effects. Is there anything else that we could use that might be less troubling, that could be just as effective but not show the kinds of extrapyramidal symptoms that we discussed earlier? That was the promise of the atypical antipsychotics. You might ask, what makes an atypical atypical? I found this advertisement in a psychiatric magazine, and I thought it was a good way to remind us that many times psychiatrists learn about these drugs in a very simplistic fashion, and we don't have to become so nervous about whether we know enough or understand it at a deep enough level. Because if you look at this advertisement, it's actually a scratch off, and it asks, do you know what makes an atypical different from a conventional antipsychotic? And so you're supposed to guess and scratch off depending on your guess. So is it the fact that it blocks D3? Could that be what makes an atypical atypical? Is it D2? Well, you probably already know the answer there because we know the conventionals block D2. Ah, here we don't have an X, and it's telling us that it's 5-HT2A blockade. So now what we're seeing with these atypical antipsychotics is that they're blocking serotonin. Well, what effect would that have? As you see here in the same picture that I showed you earlier, the horse and its rider, now the rider becomes serotonin or 5-HT2A and dopamine. What I'm trying to illustrate through this picture is that 5-HT2A inhibits the release of dopamine. So once again, we've got him reining in dopamine as the serotonin rider. So we know that atypicals are not only going to block dopamine D2, but also serotonin. And because of this, the promise was that we would not only be able to treat the positive symptoms of psychosis, but also improve the negative symptoms. How does that happen? Because interestingly, if you recall, when we block dopamine in the nigrostriatal area, so remember that's kind of the movement and balance, when we blocked dopamine in that nigrostriatal pathway, we got extrapyramidal symptoms. But now remember that we said that serotonin 5-HT2A inhibits the release of dopamine. When we knock off that rider that represents serotonin 5-HT2A, we would have the effect of increasing dopamine levels.
Wait a minute, Dr. Foster, that doesn't make any sense. We're trying to keep the dopamine level down. What do you mean you want to let it increase?
Ah, that's a good question. And it shows that you understand the effect of these drugs. what is really fascinating about the atypicals is that when you look at the density of 5-HT2A receptors in the brain, guess where you have a higher density?
I don't know. I might have read it someplace.
Okay, well, I'll end the suspense and tell you that these higher densities are found in the nigrostriatal pathway.
Oh, now I'm beginning to see.
Exactly. So what will happen is, remember we said that it's a two-sided coin. On the one side, blocking dopamine has the effect of reducing the positive symptoms of schizophrenia. But we paid the price with the other side of the coin, which is blocking dopamine in the nigrostriatal area. So blocking dopamine in the mesolimbic area is a good thing. It reduces the positive symptoms of schizophrenia. Blocking it in the nigrostriatal area is not a good thing. We get these Parkinsonism, dystonic, and akathisia symptoms. So now, what if we could increase dopamine levels in the nigrostriatal area? That would theoretically reduce the extrapyramidal symptoms. And as I said, that was the promise of the atypical antipsychotics. They don't follow a linear correlation with D2 binding affinity like the conventional antipsychotics did. In fact, a drug like quetiapine or Seroquel has almost no D2 receptor blockade effect. Aripiprazole is actually a partial agonist of dopamine 2, which means that it's producing the effects of dopamine rather than blocking them. We do see a generally lower risk of tardive dyskinesia with these drugs as well. This graphic is to help you see why that net effect of blocking 5-HT2A has had such a dramatic effect on the use of these antipsychotic agents. The use skyrocketed, and in fact, I've always been amazed by the fact that a drug like aripiprazole or Abilify, at least in the United States, is prescribed more than Viagra and Levitra, which are drugs used to treat erectile dysfunction. As you see here on this graphic, there are so many more conditions and targets for these drugs. Why? Because they were, and to an extent still are, deemed safer than the first generation antipsychotics. So they're used to treat anything from psychosis to insomnia. And along the way, Tourette's, substance abuse, autism, anxiety. And here's a list of the atypical antipsychotics, not by order of chronology, but alphabetically. Just a quick note, we mentioned that aripiprazole or Abilify is a partial agonist at the D2 receptor, and it is considered a third generation antipsychotic, as well as Latuda or lurasidone. I wanted to use this slide to let you know that probably something you already suspected, is that no drug comes without its cost. And the atypical antipsychotics come with their own side effect burden. The atypicals are associated with risk for metabolic syndrome. You may not be familiar with this. I liked to use a photograph to drive home the point of this disease known as metabolic syndrome. And in the photo, the individual was grossly overweight, obese, we would call it morbidly obese, and was drinking a big gulp, those big American sized sodas packed with sugar. And the idea behind this was to drive home the point that metabolic syndrome enhances the risk of not only heart disease, but diabetes. How do you know whether a patient is at risk? These are the factors that are required for the diagnosis. Let's start with waist circumference. For men, it's anything above 102 centimeters, and women above 88 centimeters. Triglycerides, which, if you recall, are the free-floating fats in your bloodstream, anything above 150. Now, this is interesting. We're looking at low counts of high-density lipoproteins, HDL being the good cholesterol, which eliminates the bad cholesterol from your bloodstream. You want more of that, not less. And as you see there, they are giving the levels. Blood pressure, which is elevated, you've probably already recognized that as a risk factor for heart disease. And then finally, a fasting blood glucose above 110 milligrams per deciliter. Remember, that's fasting. So while that would be within normal limits, otherwise, if you were not eating for several hours and still had a blood sugar that high, that would be of concern. So 3 or more risk factors of those that you see on the graph would be considered reason to be diagnosed with metabolic syndrome. Interestingly, though, despite the fact that they can all produce metabolic syndrome, they don't all carry the same risk. So, for example, drugs like clozapine or clozaril and olanzapine carry the highest risk. They tend to put weight on patients taking them and increase those other risk factors that we described. But probably what you will notice most dramatically in the patient who's taking these medications is that their weight gain will happen rapidly and more weight than they have ever gained in their history. More moderate effects are seen with risperidone, its metabolite paliperidone, quetiapine, and iloperidone. The lowest risk is carried by ziprasidone, aripiprazole, and lurasidone. I like to think of a mental picture of an individual zipping up their pants for ziprasidone because it's low risk for weight gain, and so they can easily get that zipper up. And it just helps me remember the effect of that drug better.
Dr. Foster, I'm so glad that you have put up a chart which explains this clearly. And I want to just tell our students that there is a warning now, a black box warning about the use of olanzapine with children and adolescents because it causes the metabolic syndrome so often. And we have, as you know, around the world a problem with children developing these symptoms of obesity and related difficulties. It's important for us to keep this in mind because olanzapine is one of the older atypicals. And even though there is this black box warning, it tends to be used quite a bit around the world. But I also wanted to ask you another question. Why would anybody want to use clozapine or olanzapine given the risk for the metabolic syndrome?
I think that's a great question. The use of clozapine is relatively limited, and it's because it has other significant risks, the most deadly being agranulocytosis. We won't go into that right now, but the idea is that the reason why you might use these drugs, for example, clozapine, is because it is the drug that works when nothing else does. And so it's used for intractable psychosis or schizophrenia, psychosis with suicidality that does not respond. These, interestingly, when you think of these two drugs, a concept that I brought up earlier again becomes relevant. It's this idea of dirty drugs being more effective, and potentially because they have so many other binding affinities that they have this shotgun effect and therefore have more impact. But the idea is that a drug, for example, like olanzapine, was studied along with other atypicals in what was called the Katie trial, the clinical antipsychotic trial of intervention effectiveness. And what they did was they compared atypicals to one conventional antipsychotic, fluphenazine. In the comparison, it was just embarrassing. They found that in general, regardless of which drug is used, first generation or atypical, patients did not take the medication on average for more than 18 months. 18 months. That means that while we're thinking that these drugs need to be used over the course of a lifetime, especially for some of the psychotic conditions, the likelihood that your patient will continue them for that long is low. The other thing that they found was that olanzapine showed more effectiveness. It wasn't a dramatic difference, but more effectiveness on average than the others. Having used this drug myself, I can tell you that it's very much like clozapine. When the other ones don't work, that one seems to shine. And so I would say that's the reason why those drugs continue to be used despite their significant side effect burden.
And olanzapine might cause less, even if you have to go up on the dosage, less extrapyramidal side effects too.
The atypicals in general tend to cause less extrapyramidal. Yes, you're right about olanzapine. And conversely, the one that would act more like a conventional antipsychotic would be a drug like risperidone. Because even at low doses, you can still see extrapyramidal symptoms with that drug in particular.
These are difficult choices to make, aren't they?
Absolutely. So let's look at some key messages that we want to get across regarding the atypicals and this metabolic syndrome. We know that second generation or atypical antipsychotics are efficacious for the treatment of psychotic disorders. We just said that they are more often associated with these metabolic adverse effects, but it is also important to be even-handed here and tell you that we can see these metabolic effects more often, just as often, with the first generation antipsychotics. The one that tends to be lowest risk is molindone or Moban. Patients with severe mental illness may have unhealthy lifestyles to begin with. So using antipsychotic agents is not the only thing that may cause them to experience metabolic syndrome. This population in general tends to exercise less, eat more unrestricted diets composed of fatty foods. They smoke more often. And in general, their lifestyle is more associated with the same risks, the cardiovascular risk and the risk of diabetes. So we can't only assume that it's the antipsychotic agents that are promoting these kinds of symptoms in our patients. And we need to stay mindful of that as we treat them. The correct diagnosis and adequate treatment of psychosis, of course, needs to take priority. So I know you just suggested that these are some hard choices to make. But if a person is at risk based on hallucinations or delusions that they experience, that risk is typically more acute than the downstream effects of the metabolic syndrome. And so typically we will treat those psychotic symptoms first and then work on the sequelae or the adverse effects of that treatment. Now that you understand a bit more about the side effects of both the first generation conventional antipsychotics and the second generation atypicals, this graphic should seem more meaningful to you. If you look at the first generation agents, you'll see that the high potency agents like haloperidol, fluphenazine, are more likely to produce extrapyramidal symptoms and TD. And then if you look at chlorpromazine, it shows less of that effect. Now let's take a quick look at weight gain with these. Remember we said chlorpromazine is a dirty drug? One of the dirty binding affinities is histamine. And we know that when patients take antihistamines for extended periods, they do gain weight. We see this all the time with the tricyclic antidepressants. So this is something to keep in mind, that it is not only the atypicals that can produce weight gain. Now look down at the atypicals, and you will see that, as we said, risperidone and its metabolite paliperidone show the greatest propensity for producing extrapyramidal side effects and even tardive dyskinesia. So don't be fooled into thinking that only the first generation antipsychotics can produce tardive. Remember what the word tardive even means. It means late occurring. So we would tend to see this symptom or this side effect later on in the course of treatment. But again, we can still see it even with the atypicals. Weight gain, we've already said, more likely to occur with clozapine and olanzapine. How should we go about monitoring our patients for these types of side effects? I think as a clinician, whether you prescribe or never prescribe for your patients, it's useful to be aware of how to monitor for these types of side effects, because you may be the first to notice one of these risk factors. So, for example, at baseline, the American Diabetes Association has recommended that the metabolic risk factors be documented. So, looking at their waist circumference, their blood pressure, fasting plasma glucose, and their lipid profile, which includes the triglycerides, high density and low density lipoproteins. Interestingly, it also includes their body mass index, which is not just their weight, but their weight in correlation with their height. And anything above 30 is considered a risk factor. The baseline is taken, but then there are recommendations about how often to go back to these risk factors to check to see whether they are changing. I can tell you that most of the psychiatrists that I have worked with do not do this. And it may be overkill, but if you are aware of these risk factors and you can notice them, perhaps this would be a wonderful opportunity for you to consult with the prescriber and explain that there are some changes happening that may place the patient at risk. Here are some interventions to consider, not only the type of intervention, but when to consider it. So, for example, if the patient is showing a 5% or greater increase in weight, a 1-point increase in body mass index, greater than 1 inch in waist circumference, or they've met the criteria now for metabolic syndrome, that would be the time to either encourage a weight reduction program, or if it seems to be directly related to the use of a particular antipsychotic, to consider switching that antipsychotic.
I'm so glad to see this. I was wondering if we were going to get back to the psychobiosocial model, Dr. Foster. You know, I was talking with an insurance representative the other day and asking if I could see a patient twice a week who had severe suicidal tendencies and had a diagnosis of schizophrenia. And that insurance person told me, I don't see why you need to do that, because you just need to up the person's medication. They have schizophrenia. She certainly didn't know about the psychobiosocial model, and I'm glad we're going to be emphasizing it now.
I'll tell you, the importance of the psychological part of this psychobiosocial model has never been more real to me than working with this population. And I will start with the psychological aspect of my own anxiety when I first started working with psychotic patients on an inpatient unit, because in that setting, you're getting some of the most floridly out of control patients that you will ever see. And sometimes they can be dangerous. I had a bodybuilder who had taken legal steroids that we discussed earlier, and that steroid resulted in psychosis. I can't tell you how fearful I felt about this male in his mid-20s, measuring 6 foot and a bodybuilder who was so strong, he literally broke the plexiglass at the nurse's station. Plexiglass is hard to break, and he crumpled it like a piece of paper.
Give him more medication.
So, well, in his case, we did have to use a combination. They call it the cocktail, the Haldol cocktail, in order just to stabilize him. So I would never suggest that we try to do therapy with someone who is violent and out of touch with reality, which in his case, there would be no conversation to be had. Although, interestingly enough, because we were in the military and I was a lieutenant colonel and he was an airman, I was able to tell him that he needed to listen to my order and to stop. And it's amazing the kind of impact that military training will have on an individual, because when he saw my rank and me taking that officious stance with him, he did stop. He was able to stop what he was doing and stand at attention.
So that speaks to knowing the person, doesn't it? And that there are ways to relate under even these severe circumstances.
I think it very much speaks to the idea that each person is an individual, and even during an acute phase of a psychotic episode, there are still ways of going about reaching that individual.
I just am so glad we're talking about this, because I think that over time, the severely mentally ill have felt that they were just treated like a symptom. Like, we just have to get rid of your hallucination. We just get rid of your delusion. But there's a person in there, and that's why we're so glad you're participating in this program, because you are the provider that is at the level of understanding them as a person and integrating the psychosocial with the biological model in caring for them.
Well, let's look at some of those psychological interventions. Why don't we pull back a bit and think about the individual as a whole? So you just brought up the idea, they're not just a set of positive symptoms. They're not even a set of negative cognitive and mood symptoms. They are an individual. And I think the best example of understanding that in the case of a psychotic episode is that many times, until that relationship has been established, you have no way of knowing whether they are thinking of harming themselves and whether they are going to continue to take these excellent medications that you're trying to use to ameliorate their symptoms.
I would just add that in other parts of the country, world, psychiatrists may have the luxury of spending time with patients. In our country, there's such a shortage that they end up being medication managers for the most part, and really aren't even allowed the time to establish relationship. Later in this course, you will be listening to a case of mine with a patient with psychosis, and he will, you will learn that he had a number of symptoms that he never discussed with anybody before he got to me. I'm going to leave you in suspense about why.
That also reminds me of a patient that I saw who was laconic. He would not answer questions. He was very quiet. I brought him into the physical exam room and I closed the door. And I don't remember why, but I took my lab coat off and I put it on the knob of the door and I proceeded to do the physical examination. And he was trembling. And I couldn't understand what was driving the fear that he seemed to be showing during this physical exam. I tried to be very understanding, tried to take my time and not rattle him. And yet he continued to show this behavior. So I stopped the exam. And I said, "What's wrong?" And he said, "I know why you put your jacket or lab coat over the knob." And I said, "Really? Why did I do that?" And he said, "Because you're covering up the camera." And so from there, we went on to a discussion that demonstrated that he was floridly paranoid and thought that his phone was being tapped, that he was being monitored in multiple ways, including obviously videographed. And so this is why the medical model does not take us to the place that is going to allow us to effectively treat a patient who doesn't trust us, who's expecting something horrible to happen to them, and who may not trust that your medicine is not a poison. So I think getting at this idea that as mental health providers, you hold just as much power as the person who holds the prescription pad has to become real through hopefully your own real life examples, and then maybe even through the ones that we just cited here. So let's look at the ways that cognitive behavioral therapy, which is an empirically supported therapy in the treatment of psychosis, can be used beyond perhaps what you've been trained to do. If you haven't learned CBT for schizophrenia or other psychotic disorders, I was hoping that this slide would help you to begin to see it through the lens of treating psychosis. So, for example, recognizing delusional thoughts is important. Remember the paranoid patient who only looked acutely anxious. Until you know that he's suffering from this paranoid delusion, it's difficult to make any kind of intervention. But then once I knew that this was his line of thinking, number one, it helped me to realize that we were starting to build trust. Because if he thought I was one of the evildoers who was out to hurt him in some way, he would have never shared that delusion with me. That then gave me an opportunity to reappraise that delusion with him. So, who are these people who are trying to hurt you? What is their intent? Is it reasonable to consider that the commander who sent you here wasn't doing it because he wanted to hurt you or poison you? What data do we have to support that being true? What do we have to support it not being true? Always with an eye toward not so much convincing, but helping them to align with you, to look for those discrepancies in facts. Another is to help them, once they have stabilized, to help them notice early signs of relapse. That can be anything from not sleeping at night, so kind of logging how much sleep they get on an average night, and noticing when that sleep goes down, or conversely, when they're sleeping a good part of the day. It may be things like they are starting to listen for clicks on the phone or some other environmental signal that suggests that they're being spied upon. It may be that they're looking for signs of being an imposter in the family members they live with. Whatever it is for that individual, the idea is that they begin to see themselves from the perspective of an observer, noticing these changes in symptomology that gives them an early warning that something's starting to deteriorate.
It's very exciting, isn't it, that we can take these approaches that we've all learned in CBT and help these people test these delusions, hallucinations. So not telling them they're just delusions, but adopting that CBT model and say, well, how would we know? Or how would we test this? And you're joining with them and helping them feel that they have some control. And it's wonderful to see how sometimes they can work through it and from the inside out recognize this must be an hallucination. Even though it still feels like it, cognitively they have a different understanding about it.
It reminds me a lot of what Jerome Frank said about the therapeutic relationship actually being the lion's share of the treatment effect. Because probably with no other population more than this particular community, is that if they don't trust in you and have that relationship, the likelihood that they're going to tell you the truth about what they're experiencing and what they're doing is low. And in fact, then thwarts the treatment itself.
You know, it reminds me, just to try to bring home the point, I had a patient that was sure people could hear his thoughts. And he was very embarrassed about it. So there was no way for him to really do reality testing. But we did establish a relationship, and he did believe I was honest. So I went in the other room, and he thought and thought and thought. And of course, I couldn't hear his thoughts. And when I came back in and told him, no, I didn't hear anything, it was the beginning of his beginning to test that. And eventually he did test it with a good friend. And now the symptom wasn't gone, but his ability to handle the symptom improved dramatically. And that's something we want to emphasize too, is these medications do not always reduce completely all the symptomology. And so it's important that the patient have other skills that they can use to manage the symptoms.
And your example to me speaks of the trust that we're describing here. He could have thought, she's just lying to me, and she did hear all my thoughts, and I am no different now than when she walked out of the room. But I think because he trusted you, when you came back and said, I didn't hear anything, he believed it. I think this leads us to the last bullet, which actually, in my mind, is the first bullet. And when I say instill hope, I'm actually talking about both you and the patient. It's so easy to lose hope with patients who are psychotic because oftentimes they'll miss their appointments, they'll stop taking the medicine, they'll do things that are dangerous. And it's easy to feel like you can't make a big enough impact to counteract all of those problems. So I think as a clinician, the first person that you need to instill hope with is yourself, and remind yourself that the medications, as Dr. Levine has said, do not take away all the symptoms. And you can have just as important an impact as any drug that they're taking. And then to instill that hope in your patient so that they are more likely to follow the homework and the plans for recovery that the two of you collaboratively develop. The next portion of the psychobiosocial model has us addressing the social aspects, and probably again, more so with this population than any, family intervention becomes so beneficial and has such an impact. Many times these individuals do not maintain jobs enough to be able to hold their own financially. And not only that, they depend on their families to help them navigate or negotiate reality. The family interventions are useful for this. The family interventions are useful not only in terms of educating the family about illness, what to expect, why the patient should not discontinue their medications abruptly or prematurely. In fact, just an aside on that one piece, I want to highlight that what I typically will tell the family is that not only is there a risk of relapse from stopping the medication prematurely, but when we do restart the medicine, they require higher levels or higher doses of it. So if we can at all avoid that, because now we know the side effect burden of either of these generations of antipsychotics carry their side effect burden. And we want to reduce that as much as possible. And so if the family understands that, they might be more inclined to say, hey, John, did you remember to take your medicine? Or let's go ahead and take your medicine and be more mindful of maintaining the routine of it. The other very important aspect of treating the family has to do with reducing the levels of what is called expressed emotion. This is a concept that was developed by George Brown, in which he discovered that families that were very close to the psychotic patient, so these aren't people who call up every month to say, how are you doing? These are the people that the patient may be living with, that the patient may be married to. these individuals, if they showed significant levels of criticism and over emotional involvement, it had such a detrimental effect that it was one of the most robust indicators of relapse and rehospitalization.
I can think of an example like that where I was dealing with a couple, young, and she was saying to him, "Come on, you can't believe there's really a voice in the air conditioner." And just the intensity of it, which she thought would help, humiliated him and made the matters much worse.
Absolutely, and I've seen that over and over again, especially with my population. I tended to have young soldiers, airmen, and I would watch their families. They were so over involved that the expression of psychotic symptoms was, in their mind, a manifestation of their bad parenting. If I had been a better parent, they wouldn't be experiencing these psychotic symptoms. They wouldn't be talking about aliens in the air duct or whatever.
Right.
And so they take these manifestations of psychosis in their loved ones so personally that they can't distance themselves enough to be supportive and warm about whatever comes their way. It's just too frightening to them.
But they can learn CBT kind of techniques too. You can teach them how to help the patient test these things rather than reacting so strongly. But to me, also, part of this psychobiosocial model is to listen to the parents or the significant others about the patient, that the mental health professionals need to do that, because oftentimes these patients can't fully tell us what's going on. And unfortunately, the systems that we have now that are so bifurcated, oftentimes that kind of two-way communication doesn't happen. And I think of a patient that was taken off of her antipsychotic by a nurse practitioner because the patient said she wanted to get pregnant. Well, of course that would be a good idea, but I wish she had listened to the parents who could have said that whenever she was off the antipsychotic, she became floridly psychotic. And in this case, that's exactly what happened, and she ended up committing suicide.
Now, that's an adverse outcome.
Yes.
I think that speaks to the last bullet, which is fostering the development of coping skills among the family members so that they can work collaboratively with the clinician who is trying to help the patient, as well as with each other, so that they can alleviate some of that stress put on the patient because they cannot deal with the expression of symptoms. This just reiterates the benefits of family interventions. We know that reducing that hostility and criticism known as expressed emotion is going to decrease relapse rates and rehospitalization, likely to increase medication adherence. We've already addressed that, and is very much a part of the psychobiosocial model. Again, social aspects of treatment, social skills training. I find this very rewarding because many times there are things that I take for granted that most people do on a daily basis that become a real chore for this population. So, for example, the simple act of saying hello to someone that they've just met, the ability to hold a conversation in a meaningful way. Remember the negative symptoms, that asociality, that lack of motivation and lack of pleasure. They can express themselves in a withdrawal from human interactions. And sometimes doing something as simple as role modeling and rehearsing a basic conversation with someone, maybe at the supermarket, maybe waiting online somewhere, has really dramatic effects. And always the important part of it is to leave them with some positive reinforcement for any effort that they make, because it gives them the impression, again, instilling hope, the belief that they can get better and things will get better for them. Of course, the ultimate is for them to use real life practice, and again, rewarding any efforts in that direction. There's not much to say, I think, regarding these holistic approaches, because we've discussed the importance of monitoring their mood and propensity for harm to self and others. The quality of life and health is something important that we all, as clinicians, can monitor and help with lifestyle changes like smoking cessation, increased activity levels, going to the doctor and making sure that they're getting other medications consistent with the treatment of any disorders that they may have. One thing that we did not address that again would be a very important role that the psychotherapist can play is to consider their responsibility to more vulnerable members of the family. So if this is an individual who is responsible for taking care of their child, which we often had in the military, a single parent taking care of their very young children while the active duty member was deployed, that had such an incredible impact, because knowing that these children were at home with a parent who could not negotiate reality in a way that allowed them to be effective and keep their children safe was critical. The other aspects of social treatments would be, is this person working? Do they want to work? Do they feel more productive and successful if they're doing even a basic job? This does not have to be, solving arithmetic equations, but it may be something as simple as bagging groceries in a supermarket. It gives them a reason to wake up in the morning, to get dressed, to interact with people, and they walk away with a paycheck that makes them feel useful. I use this graphic as a way of starting our summary to show that both the conventional and the atypical antipsychotics have their side effect burdens. Some of them overlap, some of them are separate, but it's important to keep in mind that there is no drug we can prescribe that does not carry its burdens. And finally, we'll summarize with the following. We've learned that psychosis can be the result of multiple factors. Whether it be chronic or acute, we need to consider the various precipitants as well as the history of the individual. We know that positive symptoms of psychosis are not the only targets of our treatments. Of course, you can argue that all antipsychotics have proven efficacy. And just as Dr. Levine asked, how do you decide whether you want to use one agent over another, especially if one carries a heavy side effect burden? And the answer to that question is that we need to individualize it to the specific patient. It's important to not only consider patient characteristics, but the side effect profiles of the drugs that we're using so that we give the right drug to the right individual, but it doesn't stop there because we still have to monitor the after effects. No matter what a drug says about, or I should say, no matter what a drug's side effect profile looks like, it may manifest quite differently in one specific individual. And therefore, monitoring that drug's side effects continues to be critical in any treatment. Holistic treatments are certainly the main thrust of the psychobiosocial model, and we hope that addressing not only the medications, but the psychological and social treatments for this particular population will help you to enhance positive outcomes for your patients. Thank you. And thank you, Dr. Levine, for all of your insightful questions and comments.
Thank you, Dr. Foster. I think that our students will agree that we've learned so much because of your experience with this population, vast experience in your military career, and your ability to bring a medical understanding to a mental health, psychological orientation is invaluable. Thank you so much.